Hi, my name's Keith Allen, and I'm a cardiac and vascular surgeon at the Mid-America Heart Institute in Kansas City, Missouri. I've been in practice for close to 30 years now. I'm director of research, and I'm the surgical director of our structural heart program. I've been involved in the area of structural heart since Partner One in 2008, and increasingly the surgical valves or devices that surgeons implant ultimately fail and have to be managed in some way, either with a repeat operation or increasingly we manage them with catheter-based procedures like valve-in-valve or tab-in-tab or valve-in-ring, valve-in-mac, things like that. So we're always looking to do testing on current products to see how you could facilitate future transcatheter interventions. Obviously, surgeons play a crucial role in the management of mitral valve disease. Obviously, repair is still the forefront in most surgeons' decision-making process, but obviously replacements there also. Increasingly, though, surgeons have to come to the realization that what they do is not everlasting, usually, particularly when done in younger patients. And so the field, particularly in mitral, is beginning to get a little bit murky with evolving transcatheter replacement products, potential newer repair products in addition to existing repair products. So surgeons and interventional cardiologists need to kind of learn to play in that same sandbox together. Unfortunately, there's as many different types of mitral rings as there are reported surgical techniques for mitral valve repair. Equally unfortunate, not all rings are created equal. And a lot of the rings that surgeons like to use make it very challenging, if that repair fails, to treat them with a transcatheter valve and ring solution. A lot of it has to do with how the ring is shaped or designed. Rings can be complete, incomplete, partial. They can be three-dimensional. They can be rigid, semi-rigid, completely flexible. Some are even adjustable. And depending upon the construct of the ring, some of these rings you just don't get a good result when you try to put a transcatheter valve in them. Either the ring doesn't deform correctly, or it doesn't hold the valve in place correctly, or its shape lends itself to creating perivalvular leaks. Those would be some of the key limitations. When you're looking at a current ring today, you, as a surgeon, you obviously first and foremost want to choose a ring that has features that are conducive to mitral valve repair. You don't want to shortchange the initial procedure for the potential to do a better transcatheter intervention 10 or 15 years down the road. So with that in mind, you would like to design a ring that is a complete ring that is semi-rigid. You'd love to have a ring that is saddle shaped, that fits the contour of the mitral annulus. And then more importantly, you would like a ring that when you put a transcatheter valve in it, it transforms from its kind of elliptical or oval shape to more of a circular shape, which is what our transcatheter valves look like. That's where the TransForm ring is particularly unique and particularly desirable, because it has all of the features that mitral surgeons want in a ring. It's saddle shape, complete, semi-rigid, but then it is able to be transformed from that D or kind of oval elliptical shape into a circle to accommodate the future placement of a transcatheter heart valve. We've had a lot of experience with doing bench testing on surgical valves and rings to determine their suitability for future valve in valve or valve in ring. And so we're very comfortable with taking a transcatheter valve and kind of looking at it on the bench. And that's exactly what we did with this. We took selected sizes of TransForm rings, and then using an Edwards Sapien 3 transcatheter heart valve, we simply determined what size Sapien 3 was required for each size of the TransForm rings, and determine how much volume or extra volume you needed to get a good tight fit so that the valve wouldn't embolize. And then we characterized it both just visually, but also importantly under fluoroscopy, to see how that TransForm ring actually transformed. Does it, sometimes people have monikers that sound really neat, but they don't really do what they say they do. But this indeed does truly transform from a D shape to that circularized O shape. Well, you have to understand the limitations of the current transcatheter valves. And, the biggest fear when you're doing valve in ring or valve in valve is embolization. So you need to understand the dimensions and the construct of the valve or ring that's in the patient, so that then you can put in the right size transcatheter valves. And transcatheter valves, at least the current S3 that's available in the US, comes in 23, 26, 29, and 20 millimeter sizes. And you can adjust that size by adding or subtracting. Typically we add volume to that delivery balloon of the Edwards valve to, accommodate different sizes of surgical valves or surgical rings. Be very transparent. I've been doing this for a long time, and there's lots and lots of ways to skin a cat. And anytime a surgeon tells you there's only one way to do something, that's he just doesn't have enough experience, because clearly there's a lot of ways to do different things. What the surgeon, though, has to do when he picks a device to implant in a patient, unless that patient is near the grave and clearly not going to survive even in the short or medium term, you have to be thinking about what the next procedure is going to be. But you have to pick a device that allows the patient, when that device fails, to have a solution other than another open heart operation. You hope that the repair you do on the patient will be durable and last them the rest of your life. But, we have to be realistic and understand the limits, particularly when we intervene in younger patients who have a long life expectancy ahead of them. And so you have to pick that device, valve, ring, whatever it is, that if and when it fails, the patient isn't mandated to have another open heart operation, that you now have solutions that are less invasive and hopefully as durable and as good. Well, obviously, Pat is a surgeon. By that I mean he's the type of surgeon that you would want to operate on you or a loved one or your mom or dad or brother or sister. So he engenders a lot of respect, and he engenders that respect out of consummate skill set over decades of refining how to do mitral valve surgery. And the TransForm ring is just simply a reflection of that lifetime of learning. But more importantly, it illustrates how some surgeons can look behind the green curtain, as you saw in The Wizard of Oz, and pull back that curtain and understand how, it's not always a scalpel that wins the day, and you need to set the patients up for future success. And Dr. McCarthy clearly understands that and designed a ring that does exactly that. The key takeaway for me out of all the research we continue to do in the structural and surgical space is, put your patients first. First and foremost, do the right operation in the right patient at the right time and in the right way. And there's lots of facilitating tools that help surgeons do that. Surgeons need to embrace structural heart because it's here to stay. And the TransForm ring is simply another tool in the surgeon's armamentarium that is going to allow them to give the patients not only an initial excellent mitral valve repair, but set them up for future interventions if and when that valve repair fails.